I'd like to introduce Dr. Jeff Smith and Dr. Tim Triche, who will tell us all they know about the Oncology research effort.
Okay. Thank you. Jeff, you want to make any introductory comments? Jeff?
Sure. Yes. On behalf of Thermo Fisher Scientific, we couldn't be more pleased to present Tim Triche and the fantastic work that he and his team have done with Children's Hospital of Los Angeles. This has really been a long-running labor of love between our two organizations as we've spun up and have launched what we really think is really a one-of-a-kind type of solution to address pediatric and adolescents and young adults. And so with that, I would be quite privileged and honored to introduce Tim Triche, who can present the various assets and facets of the OncoKids Oncomine Childhood Cancer Research Assay. So thank you very much, Tim.
Sure. Thank you, Jeff. All right, with that, thank you all for the invitation to present this to you. As Jeff indicated, this has indeed been a labor of love. It's been many years in the making, and this effort really is focused on one issue, and that is to address the unmet need of precision oncology, if you will, in the young. As Jeff indicated, our focus has been children, adolescent, and young adults, and the only criteria is really the type of malignancy present in this age group, because I think, as most of you appreciate, the vast majority of work in precision oncology has been focused on adults with cancer, but what has been overlooked is the fact that cancer in children and the young, and by young I mean up to 20 and 30 plus years of age. This age group has an entirely different spectrum of malignancy, and we felt that it deserved the appropriate tools to guide therapy, diagnosis, and management. So the rationale then for why develop another cancer panel is, as I've stated, because there's this gross unmet need. And it really comes down to the fact that if you look at historical survival rates for childhood cancer, they were horrible. They were by far the worst of all humans with cancer. I remember when I was in medical school, when we would see a new child with newly diagnosed leukemia in clinic, we began to talk to the parents about the funeral because there were no survivors. And that, of course, is now 90% survival rate. So there's been a huge, huge change, and a lot of that has to do with recognition of the entirely different behavior of malignancies in the young compared to adults. Surgery historically has been the mainstay as the primary treatment modality in adults. It's effectively worthless in the vast majority of children. If you do surgery alone, effectively nobody survives. So that was an important issue. But now I think we come to realize that we've been overtreating these patients as well. And I think what we've now come to recognize is that many of the patients who did not survive conventional chemotherapy are now surviving with appropriate choices of therapy. And I'll show you a very specific example of that as we go through the slides today. Frankly, a patient who I doubt would have survived had we not detected a specific defect that allowed us to treat her with one agent, and she's alive and well today. And we'll come back to that. A lot of this, of course, relates to the issue that many, many new treatment modalities have been created that are focused on a specific target. And the example I just cited is one of them. But to know if that target is present or not, you have to use some form of molecular testing, which, of course, is one of the key ingredients, if you will, in the panel that we'll be talking about. And this, all of these considerations then led to the product that Thermo Fisher markets as the Oncomine Childhood Cancer Research Assay. We at Children's, however, just termed it OncoKids because it was, I think, focuses attention on the fact that it's a childhood cancer panel. And I think the interesting thing that you'll see as we go through this is many of the features that we have put on this panel actually have applicability to not just very young children or adolescents or even young adults. We actually think the future may well be a melding together of the content of OncoKids with some of the new features from the adult panels into sort of a pan-cancer or a universal panel. But that would be a project to come in the future. But for now, we have OncoKids to meet that need for cancer in the young. So there's obviously, I think, from a pure business perspective and a practical perspective, there is a very, very robust diagnostics market, at least in the US. And I think people tend to forget that adolescent and young adult cancer is not a trivial component of the overall number of patients. It may only be 3% of the total cancer market in the US, but it's still 100,000 patients a year. That's a lot of people who would benefit from this. I think, when you consider this, that in the US alone, panels like this have tremendous, shall we say, financial implications as well. And beyond the sheer scope of the number of patients, I'd like to point out that when you treat a patient appropriately and have a favorable outcome, the, shall we say, financial burden on the healthcare system is dramatically reduced because, your best shot in cancer is always your first shot. If you get it right and you cure the patient, you're over and done at probably a relatively minimal cost. When you fail to do that, you're dealing with recurrent disease, multiple, if you will, progressive hospitalizations, additional salvage therapy, and ultimately a dismal outcome. And if even you do have survival in that setting, it's usually with profound morbidity and frequent second malignancies and ultimately debilitating death. So you want to get it right the first time around, and there are a lot of financial reasons to do that. So I think a lot of the issue that we're going to talk about really focuses on the issue that historical norms, and I, for example, refer now to in the United States, North America, and I think actually, I know in fact that we have programs in Israel as well. What is now known as Children's Oncology Group has historically worked on the premise that we look at a particular tumor group, choose a tumor, like osteosarcoma, for example, and we develop protocols that basically have historically been sort of one size fits all. Over the years, we've tried to subcategorize, for example, favorable and unfavorable, but it's still basically the same treatment, maybe just more or less chemotherapy of the same type. But if it's more aggressive tumor, we give more aggressive chemotherapy. That is not precision oncology, but it's been the best we've been able to do historically in the absence of a tool like Oncotest. So I think with the advent of tools to understand the specific features of what otherwise appear to be identical tumors, but they're not, because underneath it all at the molecular genetic level, there are distinct features that would allow one to make differences in diagnosis and treatment and management based on the unique character. I mean, one very small feature is P53. We all know that, generally speaking, a P53 mutation is not a good finding because it typically bespeaks chemo resistance for the most part, because at the heart of chemotherapy, you're attempting to create a chaotropic agent, if you will, that will disrupt DNA, and an intact wild-type P53 will generally lead to tumor cell apoptosis or programmed cell death in recognition of the chaos created in the genome as a result of the chemotherapeutic agent. In the absence of a wild-type P53, that doesn't happen, and all you do is create progressive aneuploidy and ever more aggressive clones. So finding that feature alone obviously would have huge treatment implications. But that's just the beginning, because there are hundreds of such features, and we've put many of them on this cancer panel. The other thing I think is important to recognize, I think this group knows this full well, is that the trend in all of cancer management at all ages is progressive use of molecular profiling of some type. It started with individual features, like, for example, P53 mutational analysis and RAS mutational analysis and so forth. But the advent of less expensive DNA sequencing has enabled ever broader types of analysis of cancer. And I think another trend that we've seen is that what's the sweet spot between too little and too much? And I think we all know that we could, if we wanted to, do whole genome sequencing and total RNA-seq and some form of epigenetic profiling, maybe even proteomic profiling, spend untold thousands of dollars. But what are you going to do with all that information? If you just do something like P53 analysis, you're missing the bigger picture. So somewhere in the middle is a sweet spot, and OncoKids, like Oncomine, is an attempt to find that sweet spot where we have enough information that it can help guide clinical management, and it's neither, if you will, too much or too little. And basically the content is chosen to be most useful to the clinicians who will ultimately manage the patient. So I think we also recognize that in the future, this is the inevitable path that everyone will be following in management of cancer. And I think we will see increasing progress in the overall field. The tools that we use will get better and better, but the basic idea that we are going to have to adapt ever more powerful technology to the needs of those who are treating cancer patients to identify these so-called actionable genetic defects is imperative and inevitable. OncoKids is obviously our current and best effort, but I will point out to you that even as we developed OncoKids, I think we went through 6 iterations just getting the treatment, the panel out the door so it could be used for management and treatment of patients, because the content will inevitably evolve. And one of the very, very important things is that Thermo Fisher has been a very willing partner in progressive updates to this panel as we recognize that new features have been identified and we are able to add them to the panel as needed. And we've done that, as I say, 6 iterations already. And I'm sure and you've seen the same thing in the Oncomine panel that's used in the NCI match program. And I suspect that that will continue. So just a very brief history. You've heard most of this. Basically, this was a joint development effort between Children's Hospital Los Angeles and Thermo Fisher. One of the unique things I want to point out is that panels can include many types of features. And we, from the outset, attempted to incorporate all the important ones on both the RNA and the DNA side. And I want to emphasize this. One of the unique features of this panel is a robust RNA side to the panel, complementing the DNA side. That enables us to look not just at things like mutations and copy number alterations, but things like gene fusions are really only appropriately analyzed at the RNA level. And if anyone wants to talk later about why that's true, I'll be happy to talk about it. Just trust me, you don't want to do gene fusions at the DNA level. And you also cannot do gene expression analysis at the DNA level. So from the outset, we recognized that this panel had to deal with ordinary surgical pathology specimens, that is formalin fixed paraffin embedded tissue, and we had to be able to look at both DNA and RNA. And obviously many people had reservations about the ability to look at RNA expression levels in highly degraded tissues that have been fixed in formalin, and no attempts at, shall we say, protecting RNA had been made. The reality is, as you'll see later, we've had no trouble at all with this. The technology is robust. The failure rate is on the order of 1 to 2%. So the result of this is that we can identify unique abnormalities due to the robust character of this AmpliSeq technology, and thus we've been able to use almost anything. We use formalin-fixed paraffin-embedded tissues, typically scrolls cut from the blocks. If we have to, we can scrape tissue off of glass slides. We can use needle cores. We can use frozen chunks of tissue. All of this input material has been successfully employed. So the panel itself is summarized here. We will not go over the full content here, but I do want to point out, if I can, we have about 86 hotspot targets, if you will, as listed here. These are not full-length sequences of these genes. These are known mutations that are of clinical importance. We also have 28 features where we're looking at copy number alterations, which is to say usually amplifications, obviously. Many of our known features, for example, MYC-N in childhood neuroblastoma, but many, many others, as you see here. We also have 44 full-length coding sequences of the genes included in this panel, and then multiple variations on the theme of various gene fusions from this list here, as well as a smaller cohort of expressed genes that we felt would be important to analyze in the context of these childhood malignancies. So you combine all of this and you come up with 203 unique genes, over 3,000 amplicons on the DNA side, nearly 2,000 amplicons on the RNA side. So, excuse me, to my knowledge, this is the most extensive panel of its type that at this point Thermo Fisher has created. I wanted to point out that although the content was designed specifically to deal with childhood cancer, it in fact actually touches on multiple tumors and treatment agents that have been used historically in adult cancer as well. And just as I made a list here, we won't go over all these features, but I'll just point out to you that we do, for example, detect the BRAF V600E or V600K mutations. That obviously is appropriately treated with drugs like dabrafenib and trametinib. And so we have coverage for BRAF because this also occurs in children. And we can go down through this whole list, but I think you can realize that in many respects, the content of this panel is also applicable to certain adult malignancies as well. The BRCA1, BRCA2 mutations are about the only thing in the adult world that has been identified in NCTN as important that we don't really cover. We also don't cover the DDR2s, but that again, this is a small percent of the total. So in contrast, if you look at the NCCN sarcoma guidelines, these are a list of all the tumors on the list here, and effectively all of them are covered in the OncoKids panel. So in terms of guideline-directed management, all of the common sarcomas that are included in NCCN guidelines as of February of 2019 are included. As I indicated, the BRAF mutations are identified, and at the moment, the NCCN guidelines recommend that all patients with melanoma at any age, and remember, melanoma does, of course, occur in pediatric age group as well, should be tested for the presence of these BRAF mutations. And because it is on the panel will pick up BRAF mutations in melanoma patients. And again, historically, things like this were done with single gene testing, but the NCCN guidelines now specifically recommends that clinicians should consider larger NGS panels to identify other potential targets as well, including BRAF that's not V600E and KIT and other mutations. Many, if not most, of those features are also included on the panel. So, in the world of pure pediatric cancer, if you will, the number one, of course, issue that we confront, 1/3 of all our patients are the leukemics. And I just want to point out that all of the major forms of leukemia in childhood are covered in the panel. That, of course, was a primary design goal. So all of the common fusions, particularly the ones that have historically been used in children's oncology group to, if you will, stratify the patients to high risk, medium risk, and low risk patients. These fusions have historically been done by classic cytogenetic analysis. Now, of course, we use the panel like this to identify, for example, ETV6, RUNX1, E2A, PBX1, the MLL fusions, BCR-ABL, ABL1 resistance associated mutations, and so forth. So this allows, I think, immediate sort of risk stratified therapy of patients with leukemia. Next common group, of course, in childhood cancer are the brain tumors. And again, we've targeted the most common ones, and particularly the ones that require differential management. ATRTs, or atypical teratoid rhabdoid tumors, known to have the SMARCB1, let me go back there, SMARCB1 and SMARCA4 defects, as well as in medulloblastoma, the various subgroups, depending on, for example, beta-catenin, IDH1, and so forth, MICN. All of these are identified. Ependymoma, meningioma with NF2, pilocytic astrocytomas, various grades of gliomas with things like, of course, TP53, BRAF, IDH1, and so forth, as well as the growth factor receptors like PDGF and EGFR, as well as TERT and PTEN and ATRAX. And of course, midline glioma, DIPG, histone H3 mutations, which are a hallmark signature of that lesion, again, all identified. One of the more pressing issues, particularly in the older patients, as many of you know, is the ever-increasing incidence of sarcomas after puberty, reaching a peak typically in late adolescence and young adulthood. These are the common sarcomas seen in that age group. And again, we've made every effort to cover them rather extensively. As you see here, a list of the common sarcomas that are identified in this age group and the corresponding gene mutations, because sarcomas in this age group are typically fusion gene driven. And I want to point out that these are the classic gene fusions, but for any of you who have been following the field, you probably also recognize that this is a promiscuous group of gene defects in cancer. We find many, many different partners. You'll find, just to cite one example, we'll come back to NTRK3. One of the classic ones was ETV6 and TRAC3. For those of you who are not aware of the history of this, ETV6 stands for Ewing's translocation variant 6. In other words, it was first identified in Ewing sarcoma. The next tumor here, desmoplastic small round cell tumor, also has, in this case, the EWSR1 gene, which is the classic canonical fusion gene found in Ewing sarcoma. But now instead of FLY1 or ERG, it's fused to WT1, creating an entirely different tumor. So these gene fusions, particularly when you look at both partners, have served to define both the diagnosis and, as we'll see in examples like the NTRK family, also identify candidates for treatment with newly available drugs like NTRK inhibitors. So the clinical experience to date has been, I think, very rewarding for those of us who wondered at the outset how useful this would actually be. After running over 800 cases at Children's Hospital as of sometime late last year, first of all, as I noted, we've had less than a 2% failure rate, which is extremely encouraging given the wide variety of input material available to us. I'm going to show you a case a little bit later where literally we had to take the last of a 2mm core biopsy and successfully ran the assay and ascertained a diagnosis that otherwise was not possible. The type of the starting material that we're actually getting is interesting. We're getting about a third or so of FFPE material. We do get about 30% frozen material. A lot of this comes from like bone marrow cores and that sort of thing. And we also get bone marrows, blood or peripheral blood or bone marrow in an EDTA tube, which is because of the sheer number of leukemias that we're dealing with. All of these have worked effectively equally well. The failures that we've had have been more often with the FFPE, of course, but notice with a less than 2% failure rate across all of these, it's still a rare event that even the FFPE material has been inadequate. This is an extraordinarily robust technology. I would like to emphasize that. These are some of the best success rates I've ever seen in this field. So the tumor types that we typically see are indicated here. Not surprisingly, the non-CNS solid tumors are about 38%, about a little over a third as predicted are leukemics, and about a little less than a third are the brain tumors. So we're seeing exactly the predicted spectrum of malignancies, as well as some very odd tumors, either the somatic mosaics and so forth. But the vast majority exactly follow the known incidence of different tumor types in children. You might ask, well, how often do you find an actionable or useful finding from these tumors? And the interesting thing is, I want to focus your attention on the category of negative. Only about 14% of the cases come back with no useful information. The vast majority have clinically applicable and useful information. Almost 2/3 of them have strong findings in the sense that they will cause a clinical treatment decision to be made one way or another. So nearly 2/3 of the time, once these results are available, the clinical oncologist will typically make a decision as to how to treat that patient, incorporating the information from this panel. Very often it comes in the context of a suspected diagnosis based on routine pathology with confirmation from OncoKids that assures that that diagnosis is absolutely correct, often with some very specific sub-information, like a particular type of variant and so forth, but still very important information for patient management. And I also will point out that if you look categorically between brain tumors, hematologic malignancy, and solid tumors, there's not a significant amount of difference. This is seen across all tumor types that we've analyzed to date. To give you some idea of the distribution of the types of these tumors by finding, among brain tumors, the single most common finding, of course, is diagnostic, and it's even more so in leukemia and in solid tumors. So this is perhaps one of the most important uses of the panel because it absolutely confirms the diagnosis unequivocally. And for those of you, and I'm trained as a surgical pathologist, by the way, I can assure you that having definitive information like this has been extraordinarily reassuring because we are able to remove the uncertainty that's often associated among these so-called small round cell tumors of childhood. Because as you know, many of these tumors lack defining morphologic differentiation, and they tend to look very primitive, almost embryonal, and there's a great deal of confusion between different subtypes And yet we know that the prognosis and response to treatment is utterly different between many of these malignancies. And I think just pause for a moment and think about, would you want to treat a neuroblastoma that, by the way, could potentially be treated with surgery and successfully removed, versus Ewing sarcoma, tiny little primary that has never been cured by surgery alone. So simple distinctions like that obviously have profound clinical management implications. So the fact that diagnostic findings is by far the top ranking finding in these tumors is not surprising. But there are also, interestingly, important features about prognosis. And remember, COG protocols, at least, and I think worldwide, most childhood cancer protocols rely on identification of different risk groups and risk stratified therapy. Even though we may use the same drugs overall, they're used in different combinations and to different dose levels and different dosing schedules, depending on the predicted behavior of the tumor. So prognosis is critically important, particularly in the leukemias, and that's the second most common category in which we see this. And there are also some direct therapeutic findings that say that this patient is eligible for this targeted therapy. Given the paucity of such agents overall, not surprisingly, that's probably the third ranking category. And I want to point out the last category, germline testing recommended. We are discovering that a surprising number of these patients have inherited germline defects. Oops, and I don't want to go into too much detail right now, just want to point out that at least 15% of our patients have previously unsuspected patterns of inheritance that prompts reflex to parental testing to confirm. We're not just talking about BRCA1, BRCA2. There are a whole host of these features that are clearly germline. They are present in 50% of the sequence, which means that this is not tumor related. These are features that are found in one allele of the germline material. And we frequently have, obviously, included germline material in these material. We by definition, half of the genes are from one parent, half from another. And when you see a 50% signal like this, and it's a classic inherited gene or even not so classic, that I think warrants germline testing of the parents and potentially siblings, because of the implications for malignancies in the siblings. And we have seen multiple examples of this. So if you look overall at the types of alterations to the original diagnosis, okay, because of Oncokit testing, it's very interesting. This is just one example of how things have been changed. We have seen a number of examples where we've revised the diagnosis, refined the diagnosis, or developed prognostic or therapeutic data as a result of Oncokit's testing. Only about 23% of the cases did this not happen. And so, for example, things like finding of a KIA BRAF fusion or the V600E, or ascribing the patient to a medulloblastoma subgroup, or even if you will, FGFR1 mutants, ALK mutants, or others. These are the types of features that are readily detected by the panel, which of course cannot be detected by morphologic examination or immunohistochemistry or any of the other sort of straightforward tools that are not commonly used. I want to touch for a moment on another important aspect of this. Because of the specialized character of the information that comes out of this panel, it's not a matter of issuing a written report and filing it in the patient's chart. That's probably the worst possible way of conveying this information. I think everyone recognizes that the best way to do this is face-to-face, or shall we say in this day and age, Zoom or WebEx to face-to-face. But the point is communicating between the oncologist who will be treating the patient, even the surgeons who may have removed the tissue and may or may not have to go back, the radiation therapists, the imaging folks, the routine surgical pathologists, and the molecular pathologists. And for example, these are examples of three, actually, of panels that we run, including, for example, this is, I think, the general panel with multiple disciplines represented. We also do this in connection with our brain tumor, in connection with our, so we have three ones, the brain tumors, the neuropathology conference, the solid tumor one, which includes sarcomas and other solid tumors, and the Heme Path conference that's focused on leukemia and lymphoma. And so by working directly with those who will be treating patients in those categories, we're able to, I think, best convey the information. And this is the model that I think we've seen emerge in most medical centers employing a tool like this. And we'll come back and talk about that more at the very end, as it might relate to Israel, by the way. So to give you some idea of the published documentation of the utility of this, a little over a year ago, year and a half ago, we published in the Journal of Molecular Diagnostics a validation study. And at that point, we had roughly 200 patient samples to report on, and we used that to document the utility. And the utility in that panel was, as I showed you already, extremely powerful. The figures I showed you, some of them were from that paper. And I think it's unquestionable that the panel has proved to be extraordinarily useful, to the point that each of the oncology subspecialties, whether it's liquid, brain, or solid, we now have actually either weekly or every other weekly meetings where we discuss on the order of 8 to 12 patients in each conference each week. So to give you some idea of how this plays out in a real world setting, we thought I'd show you that example that's become sort of the exemplar of the power of this panel. This was truly an exceptional patient. This was a 2-year-old girl with a neck lesion who had been referred to us from another outside institution due to progressive airway compromise. That's a nice way of saying that literally the child was suffocating and it was getting worse. She had already been intubated, and they were now considering putting her on ECMO, extracorporeal membrane oxygenation, because even the airway even though she was intubated, the airway was still collapsing because of progressive encroachment by the tumor. So with that, in somewhat of a panic, the head of our solid tumor service asked if by any chance we could run OncoKids as rapidly as possible. And I want to point out to you that our normal turnaround time, or stated turnaround time, is 2 weeks. However, if you really look at it closely, if you wanted to sort of call in all hands, you can do this in roughly 72 hours, or even a little bit less. So that is exactly what happened in this case. Within 72 hours, we had a so-called wet read. And what happened is that we found an actionable feature, and that is how this progressed. So the lesion that you see down here is from a 2 millimeter core needle biopsy, from which had been cut this H&E section that you see here, multiple sections for immunohistochemistry, a couple other assays have been performed like FISH and so forth. And then finally, with a tiny, tiny amount of leftover residual material, they sent it down to our Center for Personalized Medicine for OncoKids analysis. One of the extraordinary findings was that here we had an NTRK fusion from exon 10 at the 3' end, a perfect match at the breakpoint, and a tropomyosin 3 exon 7 fused to the NTRK exon 10. Unequivocal evidence of a perfect match. And by the way, at this point in time, this fusion had never been identified before. This is one of the unique features of this panel. It is agnostic to 5' and 3' partner pairing. If they're there and the primers have been included in the panel, any permutation or combination of a fusion will be identified. And we could get into a long discussion about why that happens and why it's important. Just suffice it to say that in the real world, allowing for the fact that you may think you have one fusion, but you may in fact have another fusion, implies that you want to have multiple possibilities for both the 3' and the 5' partners. And had we not had that, we would not have seen this fusion in this child. The interesting thing is that when you look at the panoply of features that you see in these fusions, NTRKs as a group, and this is a group of sarcomas that have been published about this time, by Bayer, who developed this particular inhibitor. The NTRK fusions, if you will, across almost 500 samples, as you see, have the NTRK1s, for example, have not been that common, nor frankly of the NTRK3s among different tumor types. But if you look at sarcoma, there is one example at this point in time of an NTRK fusion that we were able to identify in a sarcoma, this patient being the second. And it's interesting, if you look overall at these kinase-related, NTRK being such a kinase, among different types of tumors, sarcomas, which are seen here, are by far the most important group. Okay, and among these we have one-offs is the single most common category of fusion. In other words, we've never seen this one before, and that's exactly what happened with this patient as well. So the other important thing is that the response to an NTRK inhibitor is very variable. And if you look at some of the common things, historically, one of the more resistant has been soft tissue sarcoma, like you see here. But that's not really true because these are only single examples. If you continue to look at these categorically, many of the best responses have been in these soft tissue sarcomas. This was ultimately published in the New England Journal of Medicine paper. And what was not realized until that paper was published is that the best responding group are, in fact, NTRK fusions in sarcomas in the young. I don't have the paper in front of me right now, but I believe it was in the order of 90+% in sarcomas in the young, and very young in particular. It was still roughly 80+%, as I recall, in the older patients. Suffice it to say that even though the drug was not developed for use in children, it in fact obviously targets the appropriate target, the NTRK3 or NTRK, any NTRK, and it doesn't matter what fusion it was because it's NTRK that drives the tumor. So the net result was that this patient went on treatment literally within hours of the announcement of this finding. And this is, as you can see, the very large lesion that was present as of December in 2017. And within less than 2 months, just being treated with larotrectinib, you have barely detectable lesion here. I want to point out that the patient's clinical response was dramatic. Within hours of the beginning of treatment, it was clear that airway compromise was improving. Within days, she was moved out of the ICU, and within a couple of weeks, she went home from the hospital. She's come back for routine follow-up ever since. There has been no recurrence of the tumor. There's been no additional treatment. She had no surgery, she had no intervention other than that 2-millimeter needle core biopsy. She had no radiation therapy, and she had no other chemotherapy. In other words, single agent NTRK inhibitor was curative in this patient's case. And we're now out almost 2 years. Actually, we are out 2 years, and there's no evidence of recurrence. So I think it's cases like this that are compelling in that they speak to the issue that these patients do well. And this is, in fact, the patient, Michelle, and she was ultimately written up in the Wall Street Journal, and you may or may not have seen this, but this is the example that we talked about, Michelle Lowry. She's doing quite well now, by the way. So a few specific features I wanted to cover. I think, this issue of low quality input material is important. This particular patient was an 11-year-old with an old sample from 2013. The lesion was identified as a non-rhabdosarcoma. Unfortunately, it was negative for all of the usual sort of RT-PCRs. This, by the way, is something I want to emphasize. It's still common to do a panel of PCR reactions for gene fusions. They've been around for years. Everybody uses them. And you can even use FISH to try to confirm it. And you'll notice that, as was the case here, the results are often negative. And after all that testing and waiting, you end up with no answer. Why not do this panel? So in this case, we were able to secure this archival block from 2013. It was really poor quality RNA and DNA with low concentration libraries, but we ran it anyway. And lo and behold, we found a B-core, if you will, cyclin B3 fusion. And this is very interesting. It shows you the power of the technology combined with the, shall we say, the latitude and forgiveness of the underlying technology to work with really poor quality starting material. And that's, again, another whole story for another day if anyone's actually interested. But by the design of primers that are relatively close together, even highly fragmented DNA and RNA turned into DNA can be identified. In this case, obviously, again, we have a perfect fusion, and this allowed us to identify this lesion. Well, this lesion is a new type of bone sarcoma that's defined by these B-core CCNB3 gene fusions, and these are Ewing's-like tumors. They look like it under the microscope, but they don't have a classic EWSR, Fly1, or ERG, or other fusion partner. So they are Ewing's-like, but not Ewing sarcoma, and they cannot be diagnosed except by using this technology. And this is documented in 2 of the papers in the literature as indicated here. I will admit that at this point in time, we have no idea if this tumor behaves, shall we say, exactly as the Ewing's patients do or not, but it does confirm that this is a fusion-driven primitive sarcoma, and given the non-specificity, frankly, of the chemotherapy regimen used for treatment of tumors like this, it still implies that Ewing's type therapy is probably the most appropriate intervention, and that's in fact what was used for that patient. The other useful thing about this panel is that, of course, can be applied more than once. So, for example, we were able to look at longitudinal monitoring of a patient over time. And this is a patient who was diagnosed initially with a T lymphoblastic lymphoma with a leukemic phase at 30% blast and bone marrow. And at that time, after the induction period, there were still 7% blast. And even after consolidation therapy, there was about roughly 0.5% minimal residual disease. So even at the end of consolidation therapy, the patient had progressive lymphadenopathy, and a lymph node biopsy when the patient was sent to us showed effacement of the lymph node with CD3 positive and TDT positive and LMA02 positive by immunohistochemistry. We then submitted this patient's tissue for Oncotest and found, in this case, 2 dominant fusions. And this is interesting. I mentioned before that there are many classic canonical fusions, but we also find combinations of fusions. And there's, again, an interesting literature on this. A couple of years ago, a paper published by David Malkin and Irene Androulis out of Toronto showed that fusions tend to occur as a burst at a point in time, and then most of them are rapidly lost, and usually one survives as the driver of fusion for that malignancy, but sometimes more than one survives. And this is a classic example of that because they had the classic STIL1 TAL1 fusion that one finds in these leukemia lymphomas, but you also had, if you will, a PDGFRA fusion, the second most common one. That allows you to consider use of a PDGFR inhibitor. And in fact, that's what was done for this patient, but he progressively developed this D842V resistance-associated mutation. And when we did follow-up longitudinal monitoring of him and repeat of his Oncotest, we found this complex, if you will, G to A SNV, as you see here, as well as, if you will, a deletion of ACA, creating, if you will, an abnormal sequence, which is a variation of the D842V. The percent rose progressively, and unfortunately, this was not detected in the previous biopsy, but it was identifiable in the repeat biopsy, and it progressively increased, and the patient, unfortunately, ultimately did succumb to his disease, even while on PDGFR inhibitor, imatinib, because of the resistance-associated mutation. So obviously, in the future, one hopes that by identifying treatment resistance-associated mutations, one could cease therapy with a drug that's no longer effective and flex to another one. And in fact, as you know, there are now 3rd-generation imatinib type agents that overcome resistance. Those were just becoming available as this patient was coming through, and unfortunately, he was not able to be treated with one of them, unfortunately, because it may well have changed the course of events. So this issue of emergence of resistance clones, I think, is an important issue that will, with, again, progressive treatment with, sequentially, potentially multiple targeted agents, is going to become an ever more common theme to be dealt with in oncology. This PDGFR mutation is just a classic in the world of imatinib type targets, whether it's BCR-ABL, PDGFRA, c-KIT, what have you. This is a recurring theme that patients who do not undergo a complete response ultimately tend to show emergence of treatment-resistant clones. So, by doing this sequentially, of course, you can identify this. So I'd like to close and wrap this up by talking about a very important issue that I think we will probably want to talk about in connection with how a tool like this may be implemented in Israel. And that is, how does one deal with all this information? And so this is the point in the discussion where I always have to be politic and polite and point out that Thermo Fisher has created an extraordinarily useful tool, the Ion Reporter and the Ion Torrent Suite. This tool, which is where all the data that comes off of the sequencer resides, is the source of all the information that one needs. Opinions vary as to how to go about using that data. And I can tell you that after many months, years even, working with Thermo, we decided, and I think, and Jeff, correct me if I'm wrong, I think the NCI did the same thing, that for those of us who are heavily involved in things like this, we want to go to the core information, specifically the BAM files, okay? And so as you see here, there are VCFs that are available. These are filtered files. We actually, and that uses, among other things, a blacklist and hotspot filter. The blacklist is a conservative blacklist. We would rather deal with the potential false positive, false negative, so we don't use the VCFs. We pull the direct BAM files from the RNA and the DNA and bypass the VCFs. You can use the VCFs, and the calls that you get will be absolutely correct, but you do run the risk that you may miss important features. So for that reason, we pull the BAM files and analyze them directly, and we then go ahead and use a tool that we've developed, a pipeline analytic tool that allows us to look at SNVs, or variants, if you will. We call that ICE. We also have a copy number variation view. We also have the fusion view that you've seen examples of. This calls on variant databases that we have been developing, which are a combination of many, many features we'll see more about. And ultimately, the output of all of this, of course, is a report that incorporates all of these findings. This is something that we can talk more about at the end, but I think the important features that will come out of this is mutations versus variants of unknown significance. There are few of these, and there are many of these, and understanding which is really what ICE is all about, all right? We'll talk about that. Copy number variants are pretty obvious. When you have amplification of certain genes, they have a poor prognostic implication usually. Our threshold at the moment is 7. So we don't talk about 3, 4, 5, 6. We typically talk about 1, 2, or 7 or greater. But still, that is well within the range of prognostically significant CNV. Gene fusions you've already seen. Those are obvious and very easily picked up and identified and have important implications. At the moment, we are not using gene expression data clinically, but we are recording and logging the information, because ultimately we believe that looking at gene expression levels themselves will be additional important information. But one of the issues there is determining what's your reference point, what's considered, quote, normal and what's considered elevated, and we're still working on that. So all of this is done within the context of our analytic software, obviously with our molecular pathologists who develop the expertise, and perhaps most importantly, a childhood cancer database. I want to talk a little bit about that childhood cancer database because I think it's immediately relevant to your interest in Israel. Jeff will never say this, but as we thought about this, Jeff came up with coined the term International Childhood Oncology Network, or ICON, which is the front end that could give anybody anywhere in the world access to the tools that we have created at Children's Hospital, because they're immediately accessible through Amazon Web Services, as long as you have, if you will, permission to enter through a VPN tunnel. You can access the entire complex of resources that we've created on site, if you will, at the Children's Hospital Center for Personalized Medicine. This bioinformatics tool, if you will, is part of an HPC high-performance computing cluster that we have on site, on which we have mounted effectively everything that we have thought would be useful in the analysis of these cases. We've used this to create our so-called childhood cancer knowledge base. There are many details of this that I won't go into in great detail today, other than to point out that things like our OncoKids variant analysis, these are particularly focused on the single nucleotide variants. In here we have, for example, material that has come from Genome England, for example, a rich annotation base of Ensemble, Cosmic, Civic, IGCC, and so forth, and then as well as sharing features, Beacon Network, and so forth. We have a data portal that allows you to do a direct upload of, for example, those BAM files. You also can download data with permission. That's another issue. We don't want to get into data use agreements today, but that's one of the important critical determinants about downloads and even uploads, depending on where they're coming from. At the moment, there are issues in connection with the European Union, which I hope are not the case with Israel. We have not yet worked out a solution for the European Union because of data use agreements and that data privacy, the genome privacy legislation that unfortunately now prevents us from accessing data from the EU. But we can talk about that later as well. We have, for example, a number of analytic tools that we've developed. For example, to get rid of noise, we have a tool called Lab for local adjustment for background that improves variant calls. We also have, at this point, over 1,000 actually cancer samples that we've sequenced that we can compare to. But most importantly, we've also compiled features from every available online database that we've been able to identify worldwide. And all of that data is also included in what we call our childhood cancer knowledge base. So if you want to ask, for example, has this feature ever been seen before, you can click, and you won't go through all that right now, but this is an example of a page. Here's a feature, here's the associated information, the variant, where it came from. You can go dig ever deeper to find out, where it has been seen, what type of tumor, what type of patient, what age of patient, what happened to the patient, how were they treated, and so forth. So it's an ever increasingly valuable annotation and reference database for childhood, or at least I should say cancer in the young. Actually, it also includes adults. So how does one actually use this? This is the ICON network that I was talking about that we've developed in partnership with Thermo Fisher, whereby clinicians and researchers who join the ICON network, and I've lost track, and Jeff, you probably know better than I do, but I think we have at least 17 members now of the ICON network, and they're using it in different ways. Among other things, you can submit tissue, or you can submit a BAM file, or you can do a VCF file. I wouldn't recommend it, but you can. And then it can be run through CCKB, and either if you will, the person who has authorized use of CCKB can pull the information themselves, or we can generate a report that incorporates all of the findings that have been generated through our analytic tools, ICE in particular, integrated curation environment, and that can be conveyed back. We will talk in a moment about some very important specifics about this, but I think for those of you in Israel, you could go either way, but I'm suspecting initially you're probably going to want to have some form of a report and get comfortable with the character of the content and its utility, and we'll talk more about that in a moment. So I won't go through all the details of this other than to say there are multiple ways of getting the information. You obviously would want to submit sample information when you do it, regardless of how you go about doing it. But that everybody benefits at that point because we have additional information for the future. So I think some obvious points is precision oncology obviously is the way we're all going right now. And clearly this is best done by next-gen sequencing tools. I hope that's obvious after talking about this. Yes, you can use whole exomes, whole genomes and all that, but frankly, only these panels are at the moment in widespread clinical use, and they're the only ones that are widely approved for reimbursement in the United States. This really all started with the NCI Match program and Oncomine as used in that large program, which incidentally originally did not include cancer in the young, which is why we developed this. The utility, of course, is that these are relatively inexpensive, they're very reliable, they're increasingly available, and most importantly, they provide the information that clinicians actually need, as opposed to a small encyclopedia of interesting novel findings of no clinical significance. And I will point out to you, and I want to emphasize this point, there are many people, we know about Foundation Medicine and others like them, that provide vast amounts of information because the assays that they used were not necessarily designed. They weren't purpose-built, if you will. And so they generate massive amounts of data, and that data, much of it may not be useful clinically. Our goal here with OncoKids has been to filter through vast amounts of potentially interesting, but not obviously useful information, and focus on the features that either are confirmed to be clinically actionable or are potentially clinically actionable, and ignore the rest of it because there's no evidence to support its clinical significance. And to give you some idea, in cases where I've actually signed out these cases myself, for example, looking at sequence variants alone, it is not uncommon to have 10,000 variants of unknown significance in a single patient. And after using the filter and after annotating and after asking the simple question, has it ever been seen before? In what context? Did it make any difference clinically? Was it actionable? Did it have a diagnostic implication? Did it have a prognostic implication? Did it have a therapeutic implication? Did it have a familial inheritance implication? If the answer to all those questions is no, 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 and no, I don't care. That results you, and one of the cases I said in particular, I remember 10,000 VUSs were reduced to 8 features, of which only 2 were obviously clinical actionable, and we noted the other 6 as potentially important to note, but had no immediate clinical implications. That's what the tool that we're talking about does. So that implies also that interpretation is not a trivial undertaking. We have developed a great deal of experience, and most people in this field end up becoming deeply immersed in analyzing the data. And I think that's something we'll probably want to talk about at the end of this. Some people have asked us about what is the current regulatory status. This is, in the United States, you have 2 directions that you can go. You can use an FDA-approved assay. That's one way to go. We can talk about that. It's a good way to grow old while waiting for an FDA approval other than an EUA, Emergency Use Agreement. But I think most assays like this in the United States are performed as so-called laboratory developed tests in a CAP-CLIA laboratory. Without going into a lot of detail, the federal regulatory level for labs work under the supervision of a physician is under the Clinical Laboratory Improvement Act, or whatever it's called, an old piece of federal legislation to guarantee uniform quality across labs across the United States. The issue is that the practice of medicine in the United States is licensed at the state level, not the federal level. And so in an attempt to have, shall we say, uniform quality statewide and allow actually physicians who operate laboratories to offer laboratory tests outside their state, we also have the College of American Pathologists. The review these days is now actually performed by CAP using both the CAP and CLIA checklist. And if CLIA wants to, they have the right to walk in and examine a laboratory. They don't have the manpower. They don't actually, they're not able to cover all the laboratories. So they have deemed that authority to CAP, which generally does a so-called CAP-CLIA licensure examination and authorization on a 2-year cycle. And that's how most testing like this is performed in the United States. And these are therefore laboratory developed tests, or LDTs. The New York State is the hardest state in the United States for its own legislation. Oncomine does have New York State approval. We expect that if there were need to do so, and with time, almost certainly OncoKids will likewise secure New York State approval. The problem is, like the FDA, these approvals are for a specific iteration. And as I told you, we're on at least our 7th iteration now of OncoKids. And so, unfortunately, the regulatory environment always trails behind reality. LDTs allow you to bypass that and validate the test and offer it as rapidly as possible after development. It also has potential for use as a companion diagnostic. And Loxo Bayer, for example, has considered using Oncomine as one of the tools for a common companion diagnostic to authorize use of larotrectinib in particular. And I think overall, there's a broad use globally of these type of panels. But of course, that's something that in Israel, like every other company, will be governed by your local regulatory environment for practice of medicine issues. So with regard to Israel, I think I'll probably close by pointing out that I'm assuming that this panel would likely be run in Israel itself. I think, reasonably speaking, that is probably the only logical way to do this. The issue will be, how will you go about analyzing the data? And I think, realistically, if you've not done this before, there is a learning curve. And certainly, there's no reason, like other ICON members, you couldn't, in fact, use the web services to access the childhood cancer knowledge base. And then the question will come what you want to do about report generation. There's one option whereby you can simply browse the data and draw your own conclusions. I think you probably would not want to do that initially. I think initially you would probably want some form of a report. But may I point out that a report that we generated in Los Angeles, to my knowledge, has no meaningful, shall we say, significance clinically for you in Israel or any place else, because it's outside the practice of medicine authorization for us as licensed physicians in California. So it is at best a consult. So in any, oh, okay, I'm going to assume that that's other noise. So I think the point is that we can talk about use, but for example, other ICON members are getting information like this as reports, and they can then decide locally and internally, because as you know, most consults, worldwide basically, for example, a local pathologist can elect to send the case to another institution anywhere they choose, get back a report, and then they take the responsibility, the legal and practice of medicine responsibility locally to decide whether to believe that report and how to incorporate it into their diagnostic report, and then how it will be used clinically. And I'm assuming that that would be a similar mechanism in Israel. And this gets down to the most obvious point, is that also implies that the most useful way of interpreting and generating these reports, I think, is probably best done locally by the local molecular pathologist. It would be inappropriate, I think, to do it any other way. That does imply that you have a molecular pathologist to do so. And I think in the clinical implementation, though, it really goes back to an earlier comment I made. It's one thing to write a report and put it in the patient's chart. It is quite another to actually implement this in the context of those responsible for the patient care. And that's why we emphasize that we believe that even though we write the reports, they go into an integrated pathology report that incorporates everything we know about the patient. We still review every one of these cases in a multi-specialty tumor board, if you will. And I think that last point is, how do you get there? And that's something we can talk about, but there are different models that we've talked about with different people in Israel, for example, and elsewhere in the world. There are many possibilities, including, for example, some on-site exposure for those who might want to come to the CPM in Los Angeles. There's also telemedicine capabilities, or if you already have well-trained molecular pathologists in Israel who could rapidly adopt this with very little, shall we say, exposure and familiarity with the tools, it's entirely possible that you could bypass that and simply do this sort of WebEx type approach, if you will. So that is everything I have to say. I'd be happy to answer questions if you have them. And I'll try to stop sharing my screen. There we go.
So,
yes, please.
this was great, really. During your talk, I wrote at the beginning of your talk, I wrote a list of questions, and during your talk, I raised some of them because you answered them.
Good.
So the one that I raised that you answered, I just want to reiterate them, is that allelic frequency is reported. Actually, I saw your FDHFRA.
Yeah.
And so report. So there are the calls, so we can distinguish between subclones and the major driver.
Absolutely. Yes.
And also through the example that you gave in this patient, I understand that the fusions are the partners, multiple new partners can be detected.
Yes.
And also all the relevant NTRKs are included, because in the beginning it was only about
yes, all true.
So 3 questions.
Yes.
One, I think you showed an example actually, so the answer is positive. Regarding copy number variation,
yes,
can significant microdeletion be detected? As an example,
mm-hmm.
Icaros abnormalities in leukemias are usually not mutations.
Yes.
But intra-gene minor deletions, and there are other examples.
Yes. Yes, we can, for example, if there's a fusion result as a fusion as a result of a microdeletion, that itself can be detected frequently, particularly if it's a full gene sequence. And in addition, for somewhat slightly larger and potentially even these microdeletions, We will frequently on these cases also, as a supplemental process, do the, if you will, SNP arrays to identify microdeletions and microamplifications when warranted. So if there's a suspicion and we want to confirm it, I didn't show that example today, but yes, we have examples where we suspect it and we confirm it with an array like that. And if we have to, in very rare cases, we've also resorted to designing custom primers and doing a PCR reaction to identify these deletions. As you know, are particularly microdeletions is one of the hardest category of features to reliably identify. So, but this tool does seem to pick up the vast majority of the clinically important ones, and we've designed it for that purpose. But you always worry about new ones that you didn't think of, and then we can do these other things if we have to.
So the other question, it's one question about two issues. What is, and I'm saying this as a general for all the listeners, to as an introduction to for all the listeners. So we, through mutation analysis, biomarkers are being developed for the use of specific drugs. For example, mutational load is a surrogate marker for potential activity of checkpoint inhibitors. And there are also mutational signatures. So BRCA1 and BRCA2 is not included on those arrays. However, there is a mutational signature of BRCA-like mutational signature that may be very useful for the addition of PARP inhibitors, which may be relevant, for example, some pediatric solid tumors or brain tumors. So can you diagnose these two from the amount of genes that are being analyzed on the Oncotest?
Oh yes, you certainly can. I mean, the granddaddy of them all, for example, as I'm sure you're aware, is osteosarcoma. Osteosarcoma is an absolute genomic train wreck. And there are such an overwhelming number of SNVs in the osteosarcoma that it's clear that you have exactly this problem, that you have an overwhelming mutational burden. Same thing happens with some of the glioblastoma multiformes, the GBMs. You can readily distinguish a high mutational burden from a low mutational burden from the sheer number of what we call VUSs initially, you know, the VCF file, if you will. What we have not done is actually developed a tool yet that would give you sort of a numerical index of, shall we say, mutational burden. But it could easily be done because there are so many features and full-length genes on the panel that I think it's not at all unreasonable to get an index of mutational burden, if you will, from any sample that's run. Our problem is that at this point in time, we have not actually been using too much immunotherapy in childhood cancer, which probably, is something that will change over time. But that's one of the virtues of the childhood cancer knowledge base I talked about, is I think that as more and more information is accumulated, we can begin to develop those tools because the knowledge base has every case in it, has every VCF, every, the numerical, the number of VCFs found in every given patient. So it would be possible to extract information like that and develop, quote, biomarker profiles. We ourselves have not yet done that, however.
Yeah, but so in the second question related to this is, so what is called mutational signature. So the type of mutation define a certain pathway that may be affected. I gave the example of the BRCA because it's relevant for PARP inhibitors.
Yes. Yeah, and that's something that I think going forward, we would like to do. We have not, as I say, done it yet. There's a little caveat there, and Jeff Smith may want to talk about this more, but we are seriously considering combining elements of OncoKids with the new version of the NCI match program, Oncomine Comprehensive version 3+, I think it is. It turns out that OncoKids has the most extensive RNA side, and the OCAV3+ has the most extensive DNA content. And with a little bit of fiddling, we could incorporate the missing features from the DNA side of OncoKids and pick up BRCA1 and BRCA2 as part of the bargain, if you will. We believe that could potentially create a so-called, pan-cancer, Oncomine assay that would cover all age groups. And that's kind of the next project I think that we have in mind. And I'm hoping that we will do that. And if we do, we will pick up BRCA1, BRCA2, and I suspect we could pick up those signatures. So that is a developmental project, another part of our partnership.
Yeah, and Tim, I'll just add to that. So what is being conceptualized that you just described is actually the Oncomine Comprehensive Plus DNA and the OncoKids RNA.
Right.
The Oncomine Comprehensive Plus is the assay that has just gone live in multiple labs across Israel. So I think there's already some level of familiarity with that particular DNA component. So that might be something to explore over time.
Yeah, and actually thank you, Jeff, also for reminding me, people have asked us, do you really have to run all of OncoKids at the same time? The actual answer is no. In some cases, for example, leukemic, where the big question is, which translocation do we have to worry about? We've also, for example, just run the RNA side of the panel. So as Jeff indicates, you can do some mix and match here. If you wanted to, you could run the RNA side of OncoKids with the DNA side from the OCA-V3 or whatever the local terminology is. So I think that's one of the things that is very useful about this, because you have both an RNA and a DNA side that handled separately, and they could be run separately if that's your local clinical need at the moment. So you could in fact pick up BRCA1, BRCA2 by running OncoKids RNA with the new version of the Oncomine Comprehensive that picks up the BRCA1, BRCA2.
Do the DNA in OncoKids include genes that are not included in the big Oncomine, whatever it is called?
You have an amazing ability to go right for the Achilles heel. I'm going to let Jeff handle this one, but this is the question that I keep raising. I forget the number, but I think there's something like 6 or 7 genes that we think are important that are in OncoKids DNA that are not on this comprehensive panel. And the question I've posed before, sorry to embarrass you, Jeff, is why in the world can't we just add them to that panel? And I think the answer I've had from Jeff before is we already put so many features in, we're maxed out. But I don't know if that's a correct statement, Jeff. You might want to respond to my comment.
Well, that might be a dated conversation, Tim, and I think it might be related to Oncomine Comprehensive version 3. So that is the NCI match assay that was built in order to address the pediatric match component of NCI match.
Yeah.
Now, what we're referring to in Oncomine Comprehensive Plus is this 500 gene panel.
Yeah.
And I don't know if we have done the overlap between OncoKids and the 500 gene panel.
Good point.
So we may end up, we may have, maybe not by chance, but maybe by just sheer number, we've accommodated those 6 or 7 genes that you had previously identified.
Yeah, so it may be. Yeah, we asked Jeff, we should do that. We should look. So it may actually already be possible. We just had not, as Jeff said, sat down and looked at the missing content from the NCI match program compared to the 500 gene panel. It may be that it's already there. We should probably take that look. We will do that.
Yeah, because it is the RNA panel. I mean, RNA fusions are really more common and more critical. Forget leukemia. I mean, you gave lots of sarcomas in the pediatric world.
I'll tell you one other little thing too, and this is sort of unofficial, but we've seen it ourselves. You asked, well, have you really thought about all possible permutations and combinations in the gene fusions? Well, there's an interesting technology wrinkle in this technology, the AmpliSeq technology, that people don't think about. Remember that you're doing PCR back and forth, right? So you can kind of have a mini version of a 5' or a 3' race, i.e. where you just keep going. You don't get a lot of bases, but you may get 30 or 40 bases into unknown territory. And so you see these little tails hanging off with nothing out there. If you cleave your sequence and blast that sequence, for example, you can find completely novel fusions that were not previously included. And we have done that before, by the way. And sometimes that happens that you say, wait a minute, the aligner, the data was there, but the aligner didn't put the pieces together. Then you go look and you say, hey, wait a minute, here's all these other reads with these fingers going this way, and you put the two together and you get a perfect match. Or in some cases, it's not included, but now you know that it's there because the blast search showed that unequivocally this is a previously unreported partner. So there's tremendous versatility on the gene fusion side.
And that's why, especially in RNA, because it's so challenging, the collaboration with your team will be essential to implement this in Israel.
Yeah. Yeah, it'd be fun too. So. I think I put everybody to sleep. So must be bedtime in Israel now, right?
Later for
You know, while people are maybe thinking about their final questions, if there are any, I just want to emphasize one thing that, you know, is not formally part of this presentation, but I think, you know, when we went into this project, you know, we went into it with a simple question in mind. You know, we felt that the cancer in the young, you know, group of cancer patients were really ill-served by just about everybody, actually, because no one was paying attention. And there really weren't appropriate tools for dealing with children with cancer as they were emerging for adult cancer. Yes, the NCI Match program was the beginning of it, but also just look at pharma's development of tools like immuno-oncology agents and so forth. What I find so interesting is that this panel and this tool really does authorize, if you will, off-label use of existing therapeutics developed in the adult cancer world. Larotrectinib is just one example. I think there are others. Immunomodulating agents, I think, are also going to be another opportunity, as you indicated, as we develop tools for assessing mutational burden and pathways and PARP inhibitor use and so forth. None of this would have been possible, of course, if we hadn't developed the panel. And at the outset, one of the things that we realized very quickly is we did not have the means, you know, the finances, the people, and frankly, the opportunity to create this on our own. And we're extraordinarily fortunate that Thermo agreed to do this because, you know, I don't think Thermo's going to get rich on this. But the point is, it addresses an absolute unmet need. And I think one of the real values is that Thermo brought to the table many things, not just reagents. Thermo has a whole team that focused on content and how to create the content and evaluate it in the larger worldwide context of peer-reviewed literature. They also have been critically important in evaluating things like primer performance. I'll give you a little insight. When we have had weekly meetings on Thursdays for what, 4 years now, where literally, you know, a dozen people from Thermo and a dozen people from our side have sat there for an hour going over data from cases that we've run and saying, well, you know, this primer pair looks like we're yielding sort of a low reaction product and there might be some cross-reactivity with another primer. Thermo would go back and then redesign the primers, and then we would run it again, and bingo, problem solved. So this has been an iterative collaboration between ourselves and Thermo. It absolutely would not have been possible without that. And from your perspective, I think what's important to know is that this has been vetted through so many people for so many cases for so long now that I think that's why you're looking at a 2% failure rate, because all of the usual failures, all the reasons that things fail have been addressed successfully. And we now, I remember initially we had a couple of fusions of brain tumors that were beastly difficult. I think they may have been microdeletions, as a matter of fact. And the issue was we just can't see them, and we know they're there. And we have validated specimens that where we know it's there, but we're not seeing it. We solved the problem. We see them now. So I want to emphasize that this is not some new product that, you know, whose performance characteristics have not yet been worked out. They have been exhaustively worked out. And I think it's safe to say that there is no other tool at this level of maturity that I'm aware of, at least, in the whole field of cancer in the young. So, I mean, we use it with absolute confidence, and the consequence of this has been effectively 100% adoption by our pediatric oncologists. And it's now extending. We have this bizarre situation in the US that you may or may not have. For example, we're all part of Norris Comprehensive Cancer Center at USC. There's one little problem. All of the adults are seen on the main medical campus, and all the children are seen at Children's Hospital, 15 minutes away. You would think that 15 minutes would not matter, makes all the difference in the world. We get patients who should really be treated on our protocols at Children's Hospital, admitted at Norris Cancer Hospital, who have clear-cut childhood cancers, and they don't necessarily get oncokids, and they don't necessarily get treated the same way. We are slowly but progressively doing so. But I will tell you that I don't know how you handle this age, like 15 and under and 16 and above, and whether you're having the same issues where the older, quote, cancer, the young patients are admitted in adult hospitals. But certainly the hardest thing for us has not been development of this panel. It has been using it in patients who have childhood cancers, whether they're 6 years old or 35 years old. And we honestly believe that if you want to improve outcomes in the AYA population, this is the tool that you want to use, but you have to figure out how to get it implemented in an adult cancer environment. Oh, by the way, Jeff did some numbers. Jeff, you can correct me if I'm wrong. Someone asked the question, well, how important is that age range? And actually, Jeff, didn't you do the numbers? It's what, 3 times more patients in the AYA population than in the pediatric population, by the way.
Yeah, we partner with Ulman so the Ulman Cancer Fund out of Baltimore, and so they've really kind of numbered out the number of patients in that AYA designation, and as Tim said, there's probably about 3 times the number that are under 16 years of age, which was surprising, I think, to many people. But what that's telling you is that that's a high number of people that are probably not being treated effectively because they're being treated as an adult rather than, one that has a childhood cancer.
Without a doubt. So in Israel, I don't know how you've structured the treatment of these patients, but I would urge you to consider that because there are more AYAs at risk than there are our conventional pediatric population. And we haven't solved the problem yet either, by the way. We're making progress, but it's been the hardest problem. Not the panel itself, not the use of the panel, but getting it out to the even larger AYA population. So.
I know we're closing in on time. So I think one of the aspects that I think I saw multiple questions coming in from multiple of you about how to gain access to ICON. Mm-hmm. So I think that highlights the fact that many of you see the value in such a resource. And really, it just means that you are not only willing to benefit from ICON, but also willing to contribute to ICON, because the strength of ICON is the collective experience of everyone that's involved from a global perspective. And so, we will be able to provide you with a subscription agreement, which simply does state that you're running Oncomine Comprehensive or Oncomine Childhood Cancer Research Assay, and that you are willing to contribute masked data, but data nonetheless that would enable us to better understand prevalent data of certain lesions. And so, if there's that appetite from any of your given institutions, please do let Lior and I know, and we can start that process. I agree that I think this is the very early parts of a very productive partnership with CHLA. So, so I guess before we close, any other questions among the group assembled here?
Yeah, Jeff, the one thing maybe I could just mention, 2 things. First, a question, and second, a statement. Do we have the data use agreement problem solved with Israel? Do you remember?
I do not know. I think that was, Alex was working on that.
Yeah. So let us pray. Israel, I assume, does not use the GPCR, whatever it is, the data for genomic data protection legislation used in the EU. That's important because we've not yet cracked that nut, as I indicated earlier. So I don't believe Israel does use the same criteria, but this has been an issue about wholesale sharing of these genomic data files, just so you know, okay?
Unfortunately, we do.
Oh.
Yeah, I know that.
Oh, no. Oh, dear. Well, let us hope that, we can get the lawyers to actually talk to one another productively. Oh, my God. Oh, well. As Jeff has heard me say, more than once. There was once a movie in the United States, I think it was called The War of the Roses, about a divorce between a family by the name of Rose. And there was an immortal line in there, what do you call 500 lawyers on the bottom of the ocean?
But
Well,
Tim,
good start.
we did solve it in different ways. You know, it's belong to the how you definition of data processor or data controller. We can solve that.
Okay, that's really encouraging.
I have a feeling this is solvable, and the reason I say so is because I also sit in IRBs, and the commercial pharma have somehow solving this problem, you know, because
good.
they collect now genomic for pharmacogenomic studies.
Yes, yes.
So I think there, you know, I think there will be a way to solve this. Europe is a huge problem now.
Oh, golly, is it ever.
Now, by this
Yes.
very populistic, but you know, it's also, you know, deteriorating in Israel. It's not that.
Yeah. Well, this is wonderful news, though, because if pharma's doing it, we should be able to do it as well. So if we could use that model, that would be extraordinarily helpful. But fortunately, Jeff and fellow John Sherlock and Thermo Fisher have been dealing with this, and we're trying to work on our end as well. We've put multiple lawyers on the problem at CHLA as well, by the way. So we are working on a solution, and working together, I'm confident that we can come up with a solution. The other minor point I wanted to make at the end of the hour is that we have also been having ongoing discussions, you know, with Schneider Children's and Chiba, by the way, and you know, both of whom, as you probably are aware, have expressed interest in the same panel. And I think, you know, one of the take-home messages from there that I've gleaned anyway is that there certainly is an appetite for this, and certainly at Chiba, for example, there's certainly the infrastructure in place in terms of the molecular pathology program and so forth that would enable this. And I think one of the things that I can't address from this end, but you all are in a much better position to address, is what do you do when you have different institutions with different levels of sophistication, expertise, and resources, and you're going to implement a tool as sophisticated as this? I think one of the obvious things is that cooperativity and working together such that the expertise that may exist in one facility can be deployed or used in some fashion in other institutions that may not have that access is really critically important, because what we don't recommend, of course, is sort of simple, facile use of the assay without understanding implications and how to put them into practical clinical use. And one thing I've encountered over and over again is, how do you create the communication bridge between the oncologists who are going to treat the patient and the people doing the diagnostics? Even something as simple as, who signed out the biopsy in surgical pathology, and did they even know about this test? For example, what you do not want to do, in my opinion, is have the oncologist order the test separately of the routine pathology, because then you set yourself up for the disastrous possibility of having a routine surgical pathology report that says one thing and an Oncokids report that says something else. They may, in fact, complement one another, but it could create the appearance of two different diagnoses, which you obviously don't want on the patient. So this issue of cooperativity and working together at all levels between the routine pathology, the molecular pathology, and the oncologist, I think is imperative. And the single best solution is these combined molecular tumor boards. So I would encourage you to think about that as you think about deploying not just this tool, but any of these sort of advanced molecular diagnostics. It's very important to use the information in the appropriate context. And I'll stop preaching. Okay, sorry.
That's part of the solution.
Yeah.
I would like to thank you all. I would like to thank Oncotest, Thermo Fisher, and both of you, Tim and Jeff, for the excellent talk. And we all learned a lot from this talk.
I'm very glad to hear that. And it was a pleasure, I assure you. Okay. With that, I may go on to my next meeting then if there are no other questions.